Hello, everyone. It's Michael Shermer, and it's time for another episode of The Michael Shermer Show. This one brought to you by Brilliant. Brilliant is the online learning platform that allows you to learn about interesting and important topics through a fun and interactive method of teaching that enables anyone to master almost any topic from basics to advanced in short, easy-to-follow lessons. Let me give you an example. As you know, I'm a historian of science and a social scientist, but I secretly always wanted to be an astrophysicist. It's just such a cool profession to be. And in fact, the first course I ever took in college was on astronomy. So I love this subject, but I know nothing about it. So I went to Brilliant. Here's how it works. You just grab your phone, you download the app right there. It says Brilliant. You touch it, opens right up. I went to the astrophysics course, and I opened the first lesson, which was on matter. And it explains what matter is, the different kinds of matters that we find here on Earth, including solid, liquid, and gaseous. I knew that, but I didn't really know much about how to think about it from a physics perspective. And then I hit my first equation. Panic time. Not really. The whole thing lasts less than 5 minutes, and I've learned something about matter, about how to calculate density, and so on. That's astonishing for somebody like me who knows nothing about physics, much less astrophysics. You too could do this. Go to brilliant.org/skeptic to get your free 30-day trial. And the first 200 of you will get 20% off the annual plan. So please support the podcast by supporting Brilliant. But it's not just supporting it. You get a lot of benefits out of this. Go to brilliant.org/skeptic. Get a 30-day free trial. And the first 200 of you to log in there, you get a 20% discount off the annual plan. So check it out. Again, brilliant.org/skeptic. Thanks for trying it out, and thanks for supporting the podcast. All right, here we go. What's your story? You came from Malta via Canada to the United States. Give us a little bit of background there.
I grew up in Malta in the 70s. Anybody who knows any history of Malta and the southern Mediterranean between Europe and North Africa. 70s and 80s, the whole country fell apart, social and economic upheaval. I left as a teenager with my family, went to Canada, where I went to medical school, practiced medicine, was a doctor in Canada. And then when I turned 30, roughly, around the turn of the century, migrated to the US to do a master's, because at the time, academic public health wasn't really a thing in Canada. And then it stuck. I did a master's, did a doctorate, and I've had a career here since about 2000. That's my story. So I'm Maltese originally, spent 14 years in Canada, and I've been here. My kids were born here, which I suppose makes me American.
So you have multiple passports, I presume.
Well, I'm not sure you're supposed to declare that.
Oh, okay. All right. Yeah, we don't want anybody coming after you. Yeah. Okay. So could you kind of give us a big picture look at what all these different fields are? So you're a medical doctor, but you have a master's and PhD in public health. Why do you need different degrees for those fields?
Yeah, it's a great question. Yeah, so I'm a medical doctor. So I was initially trained in primary care and emergency medicine, and I practiced emergency medicine, primary care all over the world. I practiced I was working with Doctors Without Borders in Somalia. I worked in Papua New Guinea, worked in the Philippines. So I was really doing medicine in acute circumstances. And then, while I was in Somalia, I had this, Damascene moment where I was doing a lot of good for a lot of people, but I realized that I was doing only a little bit, and then I was going to leave and nothing was going to change. And I said to myself, there must be a way to be engaged in health in a way that things actually change. And I needed to understand what that was, which is why I decided to do a master. So I went back and did a master of public health. And then I did a doctorate, which of course leads then to research. And, my master's and doctorate were in epidemiology. So I'm an epidemiologist, which broadly speaking means someone who knows the methods and spends a lot of time studying how to count illness and the causes of illness. And my own work has been largely about trauma and mental health. I've done a lot of work around anxiety and depression and trauma, both at the individual level and large scale, things like wars, disasters, etc. There's been a lot of my own science. And in the past 25 years, I've done, as you mentioned, published a lot of papers and written a lot in those fields. And since I've been Dean of School of Public Health in the past 10 years, I've also done a fair bit of trying to think bigger picture about the future of public health and where the field is headed and where it should be headed.
So when you talk about going to places like Papua New Guinea as a practicing physician, you're just helping people solve an immediate problem, essentially putting a Band-Aid on it. With public health, you're after what can I do to, improve the overall long-term health of these people and not just put a Band-Aid on the immediate problem.
Yeah, the metaphor that I've used over and over is the metaphor of the person drowning in the river. You can stand on the side of the river and you can pull one person out, pull another person out, pull one person out. And that's what medicine's doing. That's what you're doing. And you never stop and ask who's throwing them in the river to begin with. Now, of course, the world needs both. You need people to pull people out of the river, but you also need people who go upstream and say, who's throwing them in the river to begin with. And I decided that I wanted to be part of the second group, the group of people who goes upstream and says, what are the causes of why people are in the river? And that has led me into doing work on a number of things. I've done work, for example, on cities and how to build healthier cities. I've done work about the causes of migration. I've done work around economic forces and social forces, trying to understand the forces that create a healthier world. My blog is called The Healthiest Goldfish, and that's on Substack. And the reason it's called that is it's a bit of a riff on the David Foster Wallace joke, which is, you have a fish in the water, and you can give your fish the best possible doctor, and the fish can exercise all at once. But if you don't have clean water, the fish is never going to be healthy. And so I've seen my job as doing the science that understands how metaphorically to create clean water, and as a dean of school of public health, how to advance a public health that focuses on creating that better environment.
So over the long run, things like flush toilets and irrigate or plumbing systems and vaccines, these are public health measures that on average help the overall population live longer and healthier lives, separate from what medicine does specifically.
We often forget that we are living in the healthiest time by far in human history, right? Until about 150 years ago, you could expect to live till age 40. All of a sudden now we expect to live till age 80 and beyond. We've doubled human life expectancy in 150 years when human life expectancy had been the same for thousands of years, for millennia. And that change really came around the time of the Industrial Revolution with the cleaning up of cities, making sure we have clean water, clean air, safer food, opportunities to exercise. All of that transformed how we live. And I mean, what greater human advance has there been than doubling life expectancy in the past 150 years? And all of that, essentially all of that is public health.
Yeah. Yeah. And just to clarify that, it's not that nobody 150 years ago lived to be in their 70s and 80s. It's an on average. Let's say once you get past age 5, you're more likely to make it to age 10. If you make it to age 10, you're more likely to make it age 20 and so on up the scale.
That's correct. And so on average, people could expect to live till age 40. Sometimes I ask people when I speak, how many of you would make different life decisions if you expected to live till age 40? It makes an enormous difference in how you live your life. If your life expectancy you expect it to be this much versus this much. And that has emerged from creating, metaphorically, the healthier water. You talked about medicine. The distinction between what public health does and what medicine does is that medicine cures us when we're already sick. The goal of public health is to keep you from being sick to begin with.
Yeah.
And there are any number of stories and metaphors I can tell you about how to think about that. But arguably, you and I would prefer not to be sick to begin with. How many people actually raise your hand? How many people enjoy going to the doctor? You don't really want to go to the doctor. You would like to avoid it if you can. Now, if you need it, you want to have an excellent doctor. There's no question about that. But ideally, you want to be in a world where you don't have to go to the doctor at all.
And you also make a distinction between public health and, say, our healthcare system, healthcare reform that we need, why things are so expensive. That's a whole different area, right? It
is a whole different area. It doesn't mean we don't need healthcare reform. It doesn't mean we don't need all of that. But it's a whole different area than what public health tends to. In this country, data are very clear that we have better health outcomes only for the age group of over 75. When you're over 75, we have better health outcomes than other peer high-income countries. Under 75, we have worse outcomes. And why is that? Well, it's because over 75 is when you benefit most from the very expensive, very intensive health system that we have. So that is all to the good. I suppose my argument in health has always been we should have better health outcomes all throughout our lifespan, not just over 75. We spend, and I'm sure you've discussed this before in your show, we spend more on health than any other country in the world, by a lot, by about 40% more. But we have worse health outcomes than all other high-income countries. And my challenge that I often give people is, name one other sector where we spend more and get less. If I were to tell you your smartphone were to cost...
How about the military?
Well, outcomes there are very difficult to define.
Yeah.
If I were to tell you your smartphone was 40% more expensive than you can get, let's say, in Canada, but by the way, it holds less data and is slower.
Yeah. Well,
probably the smartphone market would suffer.
that quickly.
That's actually
Right.
what we accept on health all the time, which of course we shouldn't.
Okay. The conservative position is going to be that's because there's no free market for healthcare like there is for iPhone for smartphones.
Well, we can discuss.
Go ahead. Sure. Yeah.
We can discuss health system restructuring. I'm going to stay away largely from that question, but I will say one thing that I think everybody, regardless of their political stripe, can agree that one element we do not have in our health system is proper quarterbacking, people to look after us, people who typically serve a primary care type function that can help you navigate the complexities of the health system. Questions around payment and payment structure, those tend to fall more on ideological lines. But leaving those aside, all of us having providers who we know who look after us, study after study after study shows very clearly that we all benefit from that. So I think if we were to do one thing, one low-hanging fruit to touch in our health system would be to make sure that we have a layer of primary care that everybody is looked after that way.
Yeah, I agree. Well, it's like that in Germany. My wife's from Cologne, Germany, and they have a pretty effective universal healthcare system for everybody. There aren't massively long waits like you hear about in Canada or whatever. I don't know what they're doing. This is not my field, but it seems like, we should just do what somebody else is doing that's also a Western democracy and so forth, that also embraces free markets and so on and realizes that the market's not solving that problem, so let's try something else.
Well, we can have that conversation, and you use the word universal, which is of course one of the key questions in terms of how the American system is structured. That it's not universal; it's far from universal, and there are patchworks. And of course, the Affordable Care Act, or often called Obamacare, came in to try to solve some of that patchwork. It did well in some areas, not completely. There remain many Americans who do not have access to healthcare, but thinking of a system that serves everybody, universally to use your term, but serves everybody to actually optimize health is the conversation needs to be had about the American healthcare system.
Yeah. Okay, let's talk about recommendations versus mandates. I think this is where the rubber meets the road, where the tension between, the public doing things on average so everybody is better off, collective action problems. Versus individual freedom, you should do whatever you want. It seems to me like when you talk about mask mandates or vaccine mandates versus recommendations, that's where it becomes kind of politicized.
Yeah. I think the question of when do you mandate something versus when you leave it up to individuals is actually an empiric question. I think there is a science behind that about when people are more likely to do something, whether when you tell them they have to do it or whether we encourage them to do it. Let me start with sort of where the topic is hot right now and then work backwards in time. There have been some studies that have shown, for example, that people were more likely to want to mask when they were not mandated to wear a mask during COVID versus when they actually were mandated, when they were less likely to want to. Now, I've started with a hot topic intentionally. Now, let's work backwards. The truth is, I often hear, Americans don't like mandates. They don't do what they're told. Well, that's not true. Americans are mandated to do things all the time, and they do things what they're told all the time. For example, you get in your car, you wear a seatbelt. You buy a particular kind of car. And tens and hundreds of millions of Americans every night are stopping at stoplights and stop signs when there's nobody else around, right? So the truth is, well, in the annals of the passports, let's not discuss things that we should be discussing. Okay. But the truth is that we align with doing certain things when we agree as part of the social compact that we should do those things. Now, how do you get there? You get there through a combination of creating the policy and enforcement, but also changing social norms, right? Those two together, when they align, they create thick rules that stick, that we all adhere to. When you're missing one or the other, when you're missing the social acceptance or you're missing the policy and enforcement mechanism, that's when things really start crumbling. So the question, you asked me about mandates. When should we mandate? That's the question. The question is mandate is just one side of the house, right? It's the policy side of the house. Is that by itself going to work? if we don't have the social norms and the adherence to it, or is it going to make things worse?
Yeah, here I like Michelle Gelfin's research on tight versus loose cultures. I don't know if you're familiar with this, but
Yes,
yeah. So Germany is a tight culture. When the government makes recommendations, that people go, yeah, okay, we're going to do it. Italy, not so much. America's sort of in between, maybe pretty individualistic. So it's harder to get collective action problems solved if people are like cats running around doing their own thing.
Yeah, and I mean, I think there are underlying cultural differences, but I don't think those underlying cultural differences are a prohibition on creating mandates and policies and rules. I think it's really only a question of figuring out what are the appropriate mandates, policies, and rules that are going to align with cultural norms and expectations, and of course, recognizing the time scale on which they're going to be acceptable. I mean, to stick with the car example for a second, it took us 50, 60 years to get to a place where everybody wears seatbelts, has airbags, shatterproof glass, people don't drink and drive and all that. I mean, that took a long time. Now, in the context of a crisis, sometimes you have to do those things faster than other times. But whenever you do it, whether you're doing it quickly or whether you're doing it slowly, it requires careful deliberation to say, is a mandate or a rule going to achieve its desired effect, or is it going to achieve a counter effect? And a lot of that depends on the underlying culture, yes, but also on the confidence with which people see their rule, whether or not people actually believe that the mandate, the rule is necessary, whether or not it aligns with where people are at, or even if people are disagreeing, whether they have enough confidence in the rule maker to go along because they see it as necessary.
Yeah. On that analogy, more people die of smoking than from automobile accidents not wearing a seatbelt. Pretty sure that's the number, or in any case, it's pretty close. Why has smoking not been outlawed, whereas wearing a seatbelt is enforced by the law?
Yeah, no, it's a terrific question. I mean, why? Any number of things. Fundamentally, we outlaw, our combination of what we, outlawing something is an extreme form of a mandate, right, of a rule. It is, we arrive at a place where we are, as a society, comfortable with whatever position we take, whether that position is outright exclusion or whether the position is allowing things in a certain way. Let me use a different example. Let's go to driving your car. You drive your car on the highway and the speed limit is 55 miles per hour. Now, we know from the data very clearly, if you're in an accident 55 miles per hour, you're twice as likely to die than if you were driving at 35 miles per hour and 4 times more than if you're driving 25 miles per hour. So why don't we agree that the law should be no one drives over 25 miles per hour? Now, we don't, because we as a society weigh inputs. One of the inputs is safety on the road. Another input is how long it takes us to get there. And we decide collectively what we choose to find acceptable. Let's use another example, sticking with cars. Broadly speaking, I mean, there are exceptions, right? Most states, most people recognize the importance of wearing a helmet if you're driving a motorbike. Nowhere is there a rule about wearing a helmet when you're in your car. Now, if we all wore a helmet inside our car, we would also be safer, right? So we draw lines that are a combination of what we find socially acceptable and what we're willing to do in policymaking. And those lines come from a combination of science as well as what's normatively acceptable. And of course, the two shift, right? The science shifts and what we find acceptable shifts. But our role is, and by us, I mean all of us who are in the space of idea generation that influences policymaking, is to find a place where what we're willing to accept aligns with the policies we make so that these become thick rules.
Yeah. No, I think that's the right way to say it. I mean, it also depends on what the particular subject is. In the case of smoking, you have big tobacco lobbying to not make it outlawed. And same thing with guns. I mean, if you just got rid of the 400 million guns, there'd be no gun violence. But that's never going to happen.
No, and this is an excellent example. I'm glad you brought this up because, in some respects, one could argue that some of my comments are naive because I'm assuming that there is a level playing field of ideas that ideas can jostle until we can all determine we're arriving at the right place. But often there are players that make for an uneven playing field. Often those players are corporate players, big corporate players. So if you have a profit motive, mentioned tobacco companies, they will tilt the playing field of conversation so that then the regulation space is much narrower than might have been were we to have a fair cultural conversation. And it is on us as a society to recognize those undue influences and to sequester them as much as we can from a public conversation. It is not always possible, and I'm not suggesting that that can happen easily, but it certainly won't happen unless we're clear-eyed about what should happen.
Yeah. Naomi Oreskes and Eric Conway's book, The Merchants of Doubt, tracks this nicely.
Yeah.
How big tobacco did it, and then climate change and the chemical industry. And often they hired the same people, not just followed the same playbook of, doubt is our product and the jury is still out and, the science is not consensus yet and so on. But that was quite a startling revelation. Okay, talk about vaccines as an example of this. I have my son's 7 now, so when he was 4 or 5 is when the whole COVID thing kicked in, and we were shopping around for schools and so on. It was interesting to see a lot of parents were not comfortable with the idea of vaccinating their children for COVID, but it was understood that because all the schools require the standard round of MMR vaccines, for example. And while there's the occasional RFKJ kind of vaccine denier, or the occasional person that thinks there's a link between vaccines and autism, for example, those were pretty rare. Everybody's, yeah, of course, my kid's been vaccinated. Oh, yeah, it's a given. So what's the difference between that? We've gotten used to those vaccines, almost everybody, versus when COVID hit, it's like, wait a minute, are you sure the COVID vaccine has the same safety standards as these other vaccines? So talk about that.
Well, a couple of things. Number one is, I don't think it's unreasonable for any of us to take a moment and pause when you have a new technology, a new vaccine that comes into play so quickly. That's number one. So I think the human impulse to say, well, wait a second, are we sure this is safe? That seems reasonable. And I think it is on us in health to reassure people by being transparent about what we know, being transparent about the data, being honest about side effects that exist, and being clear that our best recommendation is that, yes, the vaccines work, they're effective and should be taken. So that's part A. Part B is, well, should we have mandated vaccines for children? I mean, you mentioned Western democracies earlier. As you know, in most Western European democracies, actually, COVID vaccines were not mandated for children. And why is that? Well, because we've known from early in COVID that children are less likely to get COVID. When they do get COVID, it's much less severe. And if they do get COVID, they're less likely to transmit it. So when we mandated vaccines for children, the question is, were we doing it for the children or were we doing it for us to limit transmission to us? And if we were doing it for us, what are the ethical implications of giving somebody else, a child who is their own autonomous being, let's not forget, something that benefits us? Now, I'm not saying that we shouldn't have done that. And in fact, my children, as I said in the book, we vaccinated our children. But we never had that conversation in this country. And the question to you is, should we not have had that conversation?
Yeah, of course. But that's brings me to another problem is this great Barington Declaration and Jay Bhattacharya. I've followed his career and I just saw him speak in New York City. And, what the government did to him, silencing him, and what social media companies did to silence that whole conversation that wanted to be had by a lot of people. Just listen to any of those Joe Rogan podcasts you referenced in the book. I've watched all of them. And that was disturbing. I mean, and here, I think this is the point of your book, right? That's the illiberalism of the left, that they silenced these voices that should have been heard.
That's correct. And I mentioned the Great Barrington Declaration in the book. And I also mentioned that by and large, I don't agree with many things in the Great Barrington Declaration, but I certainly have no disagreement with the fact that it should have been given a fair hearing. I certainly have no disagreement with the fact that, some of the ideas in there, including, for example, the very simple idea that there is differential risk and that we as a society may want to adopt different approaches to mitigate harm for people with different risk. I mean, different age groups had enormously different risk exposed to COVID. In this country, about 1.1 million people died from COVID. And what is not often understood is that under age of 65 was about a quarter of those, 250,000. Between 65 and 75 to 150, 75 to 85 to 150, over 85 to 150. So to put another way, in the years 2020, 21, 22, more people in the US died from a drug overdose than died from COVID under the age of 65. So there was a dramatically different risk of transmission and of severe COVID in a younger age group. It is not irrational to say that we should have created different norms of behavior, different policies governing behavior for those who were at lower risk. And at core, that's what the Great Barington Declaration was based on. But because we shut down that conversation, we never created space for the nuanced conversation about should we think about and deal with risk differently for different age groups.
Do you think the CDC and Fauci and so on made a mistake in acting more confident than they really were in terms of how much information they actually had?
Yeah, so I'm very careful in the book, and I will be careful here, to avoid the almost the temptation to look back and second guess.
Sure.
Because I do think it was a difficult time when many good people tried very hard to do well under very trying circumstances, which we can talk about. But at the level of concept, one of the things which I raise in the book is this notion of false certitude, which is that one of the challenges we collectively had around COVID is learning how to communicate in a time of social media. And social media is brand new technology, right? It's been around for 15 years, really hasn't achieved ubiquity for anything more than the past 5 to 10 years, which means when COVID hit, it was the first national, not to mention global crisis to be lived in an age of social media. And social media rewards false certitude, right? It rewards, I'm sure, Michael, you know this from your own social media. When you say something that's declarative and short and controversial, you get a lot more likes than if you say something that's nuanced and long. And you say, this may be the case, but it may also not be the case. And what happened is thoughtful scientists, good public health practitioners who have complex thoughts, who recognize that a particular action might work, might not, depending on caveats, found themselves caught in the trap of their communication being reduced to simple digital bumper sticker sound bites that then were interpreted as dispositive. And we saw this play out again and again. I mean, the obvious example, right, was in the initial statements to say, you should not wear a mask because it doesn't help. Only then to change to saying, no, you should wear a mask. Now, those statements were all based on our best available knowledge at the time and on a whole range of inputs. So in and of itself, there's nothing shameful or wrong about changing your mind. The problem was not changing your mind. The problem was that the first set of statements were so declarative and dispositive that people felt like, okay, I'm being told what to do. And then it was dizzying to be told the exact opposite without space for explanation. So it was this confluence of a rapidly evolving crisis, rapidly evolving data, and then a medium that we were uncomfortable using to communicate that pushed us into these corners of seeming to contradict ourselves.
Yeah, I think they've created a huge problem now in trust as you start the book with stories about that. I was just thinking, why don't they come out as public officials like Fauci or Francis Collins and be kind of Bayesian in their approach? Like, here's what we know this week. It may all change next week. We don't really know. I'm 60% confident that wearing masks and social isolation is a good idea, but this could all change in a week. So here's our recommendation. You make your decision to the governors or whatever. Why don't they do that?
I think we are going to see a lot more of that. I think we're going to see a lot more of that. And I think we are learning from, and in fact, as you're seeing a number of comments from people who were quite prominent during the pandemic, you can see there is a reckoning, a revisiting, a rethinking, which is appropriate. It's exactly where we should be. And in whole, I wrote this book specifically for that, to actually help catalyze some of that rethinking. And there is science on this, right? There's a cognitive psychology science, as you know, that shows that people can handle uncertainty. You know, to go to Jack Nicholson, Tom Cruise movie, A Few Good Men. When Jack Nicholson is on the stand and he says, "You can't handle the truth." Yeah. Well, of course, the moral of that movie was, yes, people can handle the truth. And the moral of COVID is people can handle the truth. People can handle complexity. And we did not give people enough credit. And we did not do what you just suggested, what you call the Bayesian approach. But I think we're going to see that in the future. I think we're learning from the moment. And you're going to see, based on the data that we have available to us right now, there are pros and cons of this approach. We think the best thing to do right now is this. But we will get back to you as soon as the data change. And I think if we do that, we will do so much better at the next outbreak.
Yeah. Here's how I portray it as a 2x2 grid, just a 2x2 grid with 4 cells. So in this cell, you have COVID-19 is going to be like Ebola or HIV. It's going to be incredibly deadly. And we shut down the economy, close the schools and so on, socially isolate. That's a hit. That's good. And then in this cell down here, that COVID is no worse than the flu, and we carry on business as usual. That's a correct projection. The problem is the other two, where COVID is super deadly, and we say, hey, let's just carry on as usual. And then you, the public official, have 50 million dead Americans on your hands, and that's on you. Why didn't you make the right decision? Or down here, COVID is really not that bad, and we close everything down and so on. So where are we now? I guess we're somewhere closer to that cell, that it wasn't that bad. It was worse than the normal cold or flu or whatever, but not like Ebola. And yet we paid a price for closing the schools and the economy.
Well, we paid a huge price. And multiple things to say from that. Number one is, I use that 2x2 table, as you know, in the book in the context of data availability and policy readiness to say, we only really can act when we have data and policy readiness. And, we end up in all sorts of troubles when we're trying to act on the off diagonal. So that's point A. Point B is the off diagonal show us that one of the biggest challenges that we face is working from a base of science, but also appreciating that science in and of itself is not enough. Science is just one input. One of the most troubling aspects of the public conversation during COVID was the rise of the mantra, follow the science. Because follow the science suggests that there is a linear relationship between science that leads directly to policy action. And of course, that is simply incorrect. Science is just one of many inputs that should inform policy action. And because science is predicated on the simplistic reduction that the outcome that we care about is narrow, and in this case, health. But you and I care about a lot more than health. We care about giving a hug and a kiss to our grandmother who happens to be dying in hospital of COVID, even though there may be a risk of us acquiring COVID, because we are weighing the risk of transmission with other things that matter to us, in this case, dignity of the people who we love. And when you say follow the science, well, the science is clear. You're around someone who's dying of COVID, you're more likely to actually get COVID. But that doesn't mean that that's what should guide our policies. Now, you mentioned schools, so let's talk about schools for a second. That was a quintessential example of this, right? In the context of a respiratory disease that is transmitted person to person, also through other animal reservoirs, but leaving that aside for a second, there is no question that the way to minimize transmission is by humans never touching one another. If we all were able to wrap ourselves in a plastic wrap, eventually transmission would have stopped quite a bit sooner. So the shutting down of schools would have made a small contribution to limiting transmission. But the price we were paying was enormous. The kids today, I think most experts agree, there's about a 6-month loss in social emotional learning and learning of subject matter. And of course, that 6 months loss is not distributed evenly. And we can talk more about the unevenness of the consequences of all this in a second. And that is a price that I don't think we should have been willing to pay. But I certainly think that we should have been honest and discussing that was the price that we were incurring. When we kept schools closed in the fall of 2020, did you hear much of a conversation that says, look, if we do this, here's what we're going to incur? No. We were swept up in an orthodoxy that privileged one outcome only, and that outcome was, symbolized by the ticker tape of COVID cases that most news organizations ran, that, by the way, didn't have an accompanying ticker tape that showed the rise in overdose deaths. That was also ticking up. And we saw things through the lens of one disease. Now, I want to be very careful, and I try to be very careful in the book. I'm not in any way minimizing the tragedy that was COVID. I'm not in any way minimizing how much success we had from a public health perspective, how many millions of lives were saved because of the rapid vaccination, the arrival at testing and screening and isolation. All of that saved millions of lives. But when we get to the end of COVID, or at least the end of acute COVID, as we are right now, and you see opinion polls say there's a 25% drop in confidence in science, after what was arguably an enormous triumph of science, I think it should make us pause and say, why is that? And it must be because people sense that the way we did things, despite our success, left something to be desired.
And the verdict on masks is that they only really work if it's an N95 tightly sealed mask. Otherwise, wearing a cloth around your face is really just virtue signaling. Is that where
Yeah,
we're at now?
the cloth is more or less not effective, but wearing a well-fitting N95 mask, no question, makes a difference. It makes a difference for you in terms of your risk of lowering risk of you getting a respiratory infection and lowers my risk of getting it from you. The challenge is not that. The challenge is the question of whether or not mandates work, because mandates assume that everybody's then going to wear a well-fitting N95 mask, and of course that's not the case. What ends up happening is ends up being a patchwork of wearing. And so the question is not whether or not a mask works for me as an individual or for you as an individual. If you want to limit your risk of transmission, it's now January when you and I are talking, of any respiratory virus, you should wear a well-fitting N95 mask. That's a different question of whether or not we should mandate everybody wears them, because the question is, will that actually make a difference for us as a society?
Yeah. Yeah, and also the inconsistent enforcement of the rules is what bothers people a lot. I remember going into the local Blaze Pizzeria here during the whole, and I forgot my mask in my car. So the manager, sir, put on your mask, put on your mask. And the guys, the couple sitting right next to me, no mask because they're eating their pizza. It's like, yeah, okay. I mean, come on. How does the virus know to go over them and into my face, but not get them? It's that. Well, I think that's what bothered me.
This is what gets to the point that we're making earlier about how rules become thick and embedded, and where we're willing to follow them, even when there isn't obvious enforcement, right? I'm willing to follow, leaving aside the fact that you may not stop at the stop sign, red light. I do. But I do largely because I know that the vast majority of us do, right? That all breaks down if we see patchy enforcement. So if we all feel like there is a common understanding, our norm aligns with the rule, we are going to do it. But we're only going to do that is if we are confident that the rule is rational, if we're confident that there is a gain that we are acquiring despite the potential loss that comes from the restriction.
Why did they close beaches and hiking trails and playgrounds?
Yes. Well, that is talk about reasons why the rules became frustrating to people. But there was never any good reason to close beaches or playgrounds or hiking trails. There's never any good reason to wear a mask when you're running with no one else around you. I mean, some of the frustrations of the moment where, in the town where I lived, playgrounds were sealed off. The park benches. I had a daughter in high school who, what does a high school kid do when she can't go to school? She goes and sits on a park bench with her friends, but she can't do that because the parks are closed off. And the number of news stories, go back to the summer of 2020, and the number of tut-tutting news stories about young people on beaches. Well, really, we should have been celebrating young people to go to the beach, because that was really quite safe, and the risk of transmission of COVID in open air spaces is really very low. I mean, there's probably cases of transmission, yes, but it's really very low. So what ends up happening is, and this is why the book is really about the book is about an abstract topic, right? Which is about the philosophical foundations on which we should base our thinking in health. Now, why does that matter? It matters because downstream of the philosophical foundations comes the bureaucracy that implements policies and restrictions that are downstream to those values. And the bureaucratic implementation of policies and regulations is blunt. It's a blunt instrument. And it is difficult to implement things that are rational to people unless they're already carefully discussed and grounded in the right kind of philosophical framing. So I'm trying to tackle the philosophical framing to avoid us making those same mistakes. It is hard to fault the local town manager for putting yellow tape around her parks when what she is being told at a higher level is, if you let anybody be in touch with anybody, there's going to be a cataclysm and you're going to be responsible for it, right? Our job is to have the compassion to recognize that the local town manager, she's not an epidemiologist. She's ultimately getting her cues from the thinking about the right ways for us to structure our society, which is why that thinking matters so much.
Yeah. So when this happens again, and I say when because it is, something like this is going to happen again, do you think we'll have a different response, more rational, along the lines you're proposing?
Well, my New Year's resolution is to lean into hope. So yeah, I do think so. And I'm trying not to have just blind hope. I say that because we're having this conversation, not because you and I are having this one conversation, but this conversation stands for many conversations that are happening. I wrote this book from a place of hope, from a belief that we can actually inflect the ideas that we have together. And as I look carefully and as you read and you see what people are saying, you can see this conversation starting to happen, Michael. You can see this conversation is beginning to become a slowly seep into the groundwater of ideas. And it wasn't here before. This conversation was not happening a year ago.
Yes, you've talked extensively in the book about race, class, and gender and so forth related to healthcare, and yet the policies that the CDC recommended, the ones we just talked about, adversely affected the poor more than the rich. Those of us that are keyboard jockeys and just write, I could do it from anywhere. I don't care if things close or not. It doesn't matter to me. But for most people, that's not the case, especially if you work in the restaurant business or something, and you're a working class person. You got to go somewhere to get your job. So really these policies were, well, I guess that's what you'd say. They're anti-liberal, right? In the traditional sense.
Yeah, let's talk about that. And I'm glad we came to this topic because it's one of the things that sort of perhaps was most heartbreaking about the pandemic. It is how this illiberal narrowness of our thinking ended up harming the people who we ostensibly, performatively were saying we're trying to help. So let's be concrete about it. Before the pandemic, 2019, anybody listening to this can go to the Bureau of Labor Statistics database, and you'll find very clear data about who could do some of their job from home. And if you divide the country into 4 quartiles, richest quartile, second richest, third richest, poorest quartile, in the richest quartile, about 60-something% of people could do their job from home. Okay, this is in the richest quartile. The other 3 quartiles, it was only a minority of people who could do their job from home. That when you get to the second quartile, it's about 40-something. By the time you get to the fourth quartile, it's only about 9% of people who can do their job from home. So we knew that only the richest 25% of Americans could actually work from home. Now, pandemic hits, everybody's worried, a lot of fear, respiratory virus transmitted person to person. What do we say? If you can work from home, work from home. Now, an equivalent statement to that would be, pandemic hits, we're all afraid, so let's protect the people who make most money and let everybody else bear the brunt of the risk, which is, of course, what happened, because in the first year of the pandemic, the people who died were the bus drivers, factory workers, people who worked in delivering Amazon, etc. One question which I often ask audiences when I speak academic audiences, I speak to academic audiences all the time. That's my ecosystem. And I have a few hundred people and I'm speaking and I say, raise your hand if you worked from home at least part of the time during COVID. And everybody raised their hand, like everybody. Then I say, put your hand down. Then I say, okay, now raise your hand if during COVID, when you work from home, you never got anyone deliver anything to you. And nobody raised their hand. Then the next question is, well, why was it okay for you to lower your risk of transmission of COVID, but people who make less money than you to be exposed to greater risk to deliver your stuff to your house? And the answer, of course, is it shouldn't be okay. That was wrong. And where did that come from? That came from our rigidity of thought that we alighted on simple solutions that put those who had less of a voice at greater risk.
Let me ask you about, this is from page 188 from your book, about LGBTQ populations, race, gender, economic class, and so on. We know how many sicken and die needlessly owing to these forces. One of the most affecting moments of my career was when I worked on quantifying excess deaths attributable to social factors in the United States in the year 2000. We found that 245,000 deaths were attributable to education deficits, 176,000 to racial segregation, 162,000 to low social support, 133,000 to individual level poverty, 119,000 to income inequality, and 39,000 to area level poverty. I'm not sure what that is, but first of all, how do you get those numbers?
Yeah, so that paper, which is published in the American Journal of Public Health, it used pretty standard epidemiologic approaches to take the effect estimate of how, let's take something like racial segregation. And you take studies that look at the effect estimate of being in a racially segregated neighborhood versus not, adjusting for many factors, and coming up with the effect estimate on impact on, say, death. Then you can do another calculation that says, okay, given that effect estimate, if we were to remove the force, let's say racial segregation, how many lives would be saved. So that's that calculation. Now, we do that calculation all the time with things like, for example, behavioral factors. So there are population attributable risks, which is what the number is called, for smoking, for exercise, for drinking. So what we did in that paper is we simply took the exact same formula and applied it to these contextual factors, right? Remember earlier we talked about the goldfish and the water, about elements of the water. Now, that doesn't mean that the link between, let's say, racial segregation and death is magical. It goes through other behavioral forces. But it is equally true from a causal chain point of view that if smoking, let's take lung cancer. What's the cause of lung cancer? Well, the immediate cause of lung cancer is molecular disruption. Take a step back. Well, a step back is smoking. Take a step back. Well, that's because you live in a neighborhood where smoking is normative. Take a step back. Well, it's because cigarettes are legal, right? These are all causes. These are all parts of the causal chain. So when you say 200,000, I can't remember the exact number, deaths are attributable to poor education, it doesn't mean that that doesn't go through other factors. It simply says it elevates and hopefully gives clarity that education is part of the causal chain that is associated with poor health.
Right. So something like an integrated versus segregated neighborhood, how is that quantified? Just the number of Black families that live in a neighborhood versus white, or some ratio? Or?
Well, yeah, no, there are actually like 5 different ways. There's actually many different ways of measuring segregation. You have something called an index of dissimilarity. So it's not just about proportion of people, but it's a mixing of people, etc. So it's actually quite a bit of an elaborate science behind it. But, they essentially are getting at whether or not neighborhoods are segregated, meaning so people of different racial groups are living together or not living together. And the science on this is pretty robust, that when you have segregated neighborhoods, you actually have poorer health outcomes for both groups.
And the causal vector there is just poor nutrition, or just quality of the air, or whatever, anything.
It's a quality of everything. That actually segregated neighborhoods tend to have worse infrastructure, fewer opportunities for exercise, less access to resources that generate health, including things like nutrition, less access to stable employment, and of course, buy assets that generate health. So it is a classic upstream factor. I go back to my river analogy that I mentioned earlier. Right? It is a classic example of something that's upriver that throws people into the river. That doesn't mean, sometimes I feel like these things generate skepticism, to use your word, because people say, well, how could that be? Well, it doesn't mean that there's not the downstream mediator between the upstream factor and health. But of course, the mediator is driven by something upstream.
Yeah, okay, that makes sense. So then what to do about it? Okay, so on the one hand, as you document in the book, life is better than it's ever been. Health, longevity, 90% of people are not impoverished, whereas a century ago, 90% of people lived in poverty around the world. So you can lift everybody up, but there's always going to be inequalities. I mean, it's just not possible that every neighborhood is going to be equal in all these outcomes. So I guess the question from a public health perspective is, to what extent should a collective action problem implemented by government versus, say, markets to solve those problems? What is it we want to do, and how much money do we want to spend doing it? And what's the sacrifice of individual freedom, to solve collective action problems like that?
Well, what I love about your questions is that you're asking 10 questions masked as one.
Yeah, go ahead.
So let me start with, in tribute to Hans Rosner, who was a population health scientist of some repute. He had this maxim where he'd say, the world is a terrible place. The world is a much better place than it's ever been. The world can become much better. And those 3 statements are all true. Yeah, and I would encourage us not to lean into the laziness of thinking to say that only one of those has to be true. Those 3 are all good. If I were to, anybody were to ask me, what time in history would you rather live? The answer is always tomorrow, because tomorrow is better than today. That doesn't mean that our job should not be to try to make tomorrow better than ever. You said there are always going to be inequality, which the answer is probably, but we can certainly narrow and reduce inequality. Now, the second part of your question is, well, what's the role of government, and how do we balance the trade-offs that we need to make to get there? And I suppose I come back to the philosophical underpinnings of what the book is about. The role of government should be dictated by and motivated by the underlying values that we wish in our society. And the values that I think Western democracies are founded on, and values which I am, perhaps as an immigrant who left a country, specifically because of absence of these values, I care deeply about this, are the values of building a society on the data, building on a society on allowing space for a plurality of ideas, building a society on a deep respect for the autonomy of individuals, for the dignity of individuals, and using that data, using those values to improve the world a step at a time. It is with those ideas in mind that then we should weigh difficult decisions, that we should weigh trade-offs, that we should say, let's be clear, we may limit some transmission of virus, but we're doing that at the expense of 6 months to a year of children's social emotional development. And let us have the conversation to say, is that worth it? Let's be clear that we may limit transmission of the virus, but to do that, you will not be able to kiss goodbye to your mother who's dying from disease. Is that something that's worth it? And I try hard in the book, as you saw, not to be dispositive in my answer. I try hard not to offer the answer and what I really think where I would fall, because I do think it's up to our collective cultural conversation to get there.
Well, yeah, that's a political question, not really a scientific question. The analogy I use is, what's the right percentage of upper income tax bracket? What is it now? 37%, I guess, or something. It used to be 79% or whatever, where you have, maximum taxation of upper income. That there's no right answer to that. It's just, well, who's in office and, who's voting for what, something like that. But when it comes down to actually making a decision. So, for example, you write in the book here, let me just read your own words here about your positions: Medicare for all, UBI, universal basic income, generous social safety net, reparations for slavery, liberal immigration policies, common sense gun safety reform. So if we look at these, like general social safety net, I mean, that sounds good, but maybe that's a little anodyne because, well, what's the number? So like, I think the United States allocates 21% of GDP for social services across the board. Canada's a little bit higher. Germany's a little tiny bit higher still, but no one's like more than 30%. No one's less than 15%. I mean, all Western democracies are somewhere in that little band there. So I guess then it comes down to, do you bump it up or do you bump it down? And that's a hard question.
That is a hard question. And I have no problem with this being a hard question. In the book, I articulate, where I sit on these questions, where I've come to in my own thinking. But I suppose I care more about the fact that we have space to discuss these questions, that we do not curtail conversation based on purely ideological bent, that we owe ourselves better than that. And by we, in this case, I'm speaking from places of Western democracies, and there's many other traditions of thought in the world that have a lot to offer us. But leaving that aside, that the principles of the Enlightenment are the ones that led us to this enormous success, this enormous human flourishing. And I'm not willing to throw those out on the ideological altar today.
Yeah, but those were traditional liberal values that I embrace as well. But it's your team, the far left, that's kind of become censorious and illiberal, squelching free speech as hate speech. And cancel culture is quite powerful. It's also there on the right. But, what we see most, particularly in academia, particularly just in the last few weeks, is, the kind of hypocrisy of these university presidents that can't denounce anti-Semitism as clearly as they would racism. And I think that's what bothers people, is that kind of hypocrisy of that.
Yeah, and look, I write this book from within the academy, and I write this book from within public health within the academy, which is in the home to a lot of us who align left and align with these progressive values. But the fact that I write this book is an effort to push back against the censoriousness, to push back against illiberal thinking, to push back against rigid orthodoxy, and to say that we in the academy, we in public health, we as a society should embrace a plurality of perspectives, that diversity means a diversity of perspectives as much as it means diversity of identities, that equity means equity for all people, that inclusion means inclusion of a variety of ideas as much as it means inclusion of all peoples. And that is, I think that builds a better academy, and I think that builds a better world. And, if you go back to my writing, I think I've been consistent about that. So I don't disagree with you that there has been a censoriousness that has come predominantly from the left. But I would actually argue that there have been several of us who have been trying to hold steady on the good ship liberalism.
Oh, good for you. I'm glad. Yeah, well, one of your talking points that your publicist sent me was, are you worried about your book being used by, I don't know, Tucker Carlson going, look, this guy's he's a former libtard and now he's on our side.
Well, that is so eloquent.
What they sound like.
No, I don't know exactly what it is. And the answer to the question is yes. And the answer to the question is I've been careful about who I speak to about this book, because I'm interested in having conversations like this one, which actually gives space to the full complexity of the ideas I'm trying to represent, and not to become a bumper sticker. And that's why I'm very clear in the book that none of this changes my core beliefs and core values, but it recognizes that those core beliefs and core values exist in the world and have to coexist in the world, but other people have different beliefs and different values. And I'm perfectly comfortable with, and in fact, I encourage and welcome the conversation with people who have different perspective and different values. And that is the kind of academy we should be building, by the way, not one that is, to use your very good word, censorious, and that limits heterodox speech.
Yeah. All right, let's talk about alternative media versus mainstream media. You talk about Joe Rogan. I know Joe. I've been on a show a bunch of times. I watched all the podcast episodes he did with Robert Malone about myocarditis, Brett Weinstein about ivermectin and other topics, and RFKJ. I watched the whole 3 hours, and the problem is when you actually look up the details, like with the RFK Jr. one, pretty much every factoid he cites is wrong. Now, maybe he's not overtly lying. I think he believes what he says. And, it's not Joe's job, I guess, in this form of alternative media to have another voice on there. If it was 60 Minutes that only had Robert Malone on to talk about myocarditis and vaccines, and they didn't talk to anybody else, we would, I think, rightfully be upset. Like, what has happened to 60 Minutes on CBS and all their journalistic standards? But, with podcasts, I mean, there's over 1 million podcasts. We just don't, it's just people are just talking to people, and we have lower journalistic standards, maybe. I don't know. But how do you think about those kind of conversations?
I suppose it doesn't fuss me. I think different venues for conversation need to have different rules, and I think that's okay. I think the proverbial speaker's corner. It's good for society to have the proverbial speaker's corner where anybody can say anything, anytime, anything they want. It's also important that within different forms of media and within different spaces, there are different expectations for rules. Just to come to universities, for example, which is where I live, I think universities are places which this is often oversimplified in public conversation. The universities are about free speech, yes, but that speech within universities is reasonably constrained when either that speech is dangerous, or when people's very, very being is being denied, or when people are speaking from a factually false place. In universities, we are about empiricism and data, and it is reasonable for us within university spaces to, with humility and with caution, to say there's certain kind of conversations that are appropriate in this university space, others that are not. Perhaps they are more appropriate on podcasts, and that's okay. I think it's fine for us as a society to have multiple spaces. Obviously, the question about what speech is tolerable, when it's tolerable, where it's tolerable, it's a question that we have debated as a country for hundreds of years, and we'll be debating for hundreds of years. And I suppose it's okay to debate it. What is not okay is to stop debating it and to come up with harsh lines that then shut off conversation about conversation.
Yeah. What is the final verdict on myocarditis and the vaccines? Was there ever anything to that? Is there anything? Is it just, 1 out of 1 billion people or a million or whatever? What's the story there?
Yeah, my read of those data is that there is something, that something is small, and and it's only in particular age groups and particular sort of gender groups. But the challenge is balancing a small and maybe uncertain risk with the potential benefits of vaccinating, particularly of young people. And it's tricky. There's no real clear answer to that. And again, the shutting down of conversation has made it difficult to sort through those data. I mean, this is difficult science, and I think the verdict is still out on this. But fundamentally, we should be clear that risk-benefit assessment is, at the end of the day, becomes a subjective assessment about what risks we're willing to tolerate and what benefits we are willing to take the risk for.
Yeah. To his credit, Joe did have on Robert Hotez, who has been an open critic of RFKJ on those issues. It would have been nice to see the two of them in the room together, which Joe tried to make happen by offering huge sums of money. But Hotez would have nothing to do with that. I can only guess why. I don't know him. I mean, one thing from my own experience of debating people like on the fringe, like creationists or Holocaust deniers or vaccine deniers, is they always have some little factoid. I mean, you need to have at your fingertips, in your head, like the 100 arguments they may make. So watching RFK Jr., he's like, didn't you read that study back in 1973 in, the Journal of Obscure Results that found that, this 0.01% of people that had the vaccine, and he goes on and on. And if you're sitting there, you go, no, I never saw that study. Oh, well, if you saw that study, you'd see I'm right. There's a risk of that.
Yeah, there is. And the question of how we arrive at scientific consensus is an interesting question in and of itself, right? And there's been plenty of instances in history where we arrived at the wrong scientific consensus, where we then change our mind, where we then revisit. I would argue, and now I realize that I come from a place of science, where I'm embedded in science, that more often than not, we get it right. More often than not, we get it right. But that doesn't mean that we should have the arrogance to think that we always get it right. It means that we should have the humility to realize that getting it right depends as much on the clarity that comes with a particular set of studies as much as it does with the discussion with studies that disagree with one is coming up with. Climate is a perfect example. The vast majority of scientists agree very clearly with the fact that the planet is warming, and a significant portion of that is attributable to human factors. That doesn't mean that there aren't some people who disagree, but the broad consensus is in that direction. And I think it is okay to say the broad consensus is in that direction, and there are particular contested areas of science, there are particular questions in it. But of course, policy cannot wait for certitude in all science. Most science is not as simple of, well, if you fall off a roof at 10 feet up, you're going to break your leg. Cause, effect, pretty simple. Let's make sure people don't fall off roofs. Much more science is much more nebulous than that. And policymaking needs to act on uncertain science all the time. And that's never going to change. In fact, you and I don't want policymaking to wait for resolved science on everything, because otherwise nothing will ever happen. So the fact that there's space for discussion is sui generis. It is exactly how it should happen. What shouldn't happen is what you called earlier, the censoriousness and closing of mind.
Yeah, when I'm trying to be sympathetic to people like Fauci and Francis Collins, I picture myself just standing there in front of the microphones, and they go, well, what do we do tomorrow? You're the boss, you're the mayor, the governor, whatever. And you're like, you can't really say, well, in a Bayesian sense, I'm going to wait and collect more data, and we're going to do the 60% of the, what do we do tomorrow? That's hard, I have to say. I don't know.
No, it is hard.
You have to offer something.
It is hard, Michael, but I think you're actually not giving yourself enough credit, because earlier in the conversation, you said what you would say. What you would say is, I have the data suggests that 60% likelihood this is the right approach, but I may get more data tonight. Today, this is what I think you should do. And tomorrow, if I have more data, I'll tell you something different. That's what you should say.
Yeah.
I think you can handle the microphone just fine.
Okay. But I don't want to be a politician. I don't know why anybody would want those jobs. Everybody hates you.
You probably have a better job. So it's okay.
I don't know. All right. I wanted to ask you about, since you write about health outcome differences from a public health perspective on race and class and so on and so forth. I was just tweeting this morning about the Johns Hopkins University DEI statement about diversity. The word diversity, privilege. The diversity word of the day was privilege, a set of unearned benefits given to people who are in a specific social group. Privileges operates at a personal, interpersonal, cultural, and institutional levels, and it provides advantages and favors to members of dominant groups at the expense of members of other groups. In the United States, this includes white people, able-bodied people, heterosexuals, cisgender people, males, Christians, middle or owning class people, middle-aged people, English-speaking people. Well, I'm all of those except for Christian because I'm an atheist. But so now I partially agree with this one line here. People in dominant groups often believe they have earned the privileges. Well, I mean, you can't earn being white or whatever. I mean, I'm not sure what they mean by that. But that is a pretty popular theme these days in academia, this whole DEI. And in what way am I privileged? Isn't it a better way to say there are people who don't have those characteristics and they're being discriminated against. That's the problem. Not that I was born white. I can't help what I was born. But if you're born black and you're being discriminated against, that's the problem, not me. That the discrimination is the problem. I don't know. How do you think about that?
Well, I think the challenge to your statement is that you're affixing the word problem to these statements to begin with. I mean, I don't think it's very difficult for you and I to agree that you have privileges and that I have privileges. I don't think it's difficult to agree that you face challenges that you've overcome through your hard work and that I face challenges overcome through my hard work. I don't think it's difficult to agree there are many others who have had fewer privileges than you've had or than I've had. All of that seems true. I think reasonable people will probably agree on that pretty quickly. And the fact that others are facing disadvantage, which you call discrimination, I think is one form of disadvantage, because of attributes that are no fault of their own, is probably also true. These are all true things. And that statement is, at face value, when you look at it, it's largely true. What is also true is that is just one piece of a much more complex puzzle. I mean, we carry advantage and disadvantage throughout our life course. We are born with a set of advantages and a set of disadvantages. When I speak in public, and because I talk about health, Michael, I often get someone raise their hand and say, what's the one thing I need to do to be as healthy as I can? And the answer I give to that is, you should choose to be born wealthy to majority group family, right? And I don't think you disagree with that. I think you see why that gets you on a path that your chances of being healthy are much more likely, right? Now, I think that's okay. I think that is okay, and I think it is the role of universities, academia, to illuminate that. That, of course, does not mean that everybody who is born wealthy in that kind of environment is not going to have disadvantages. So I feel like that statement and this moment keeps getting caught in these cultural moments where we see it as a reductive absolutism, and we then misinterpret its utility within a larger understanding.
Right. I mean, being attractive is a privilege. Being tall, particularly if you're male. I know because I'm only 5'7". I wish I was 6'1", but I'm not. So what? It's like, I don't know. It's the sense I get is like is sort of a guilt trip. Like, you're white and you've had this advantage. I mean, there's a lot of Trump voters in the Midwest that voted for Trump. That's like, where's my white privilege? I'm dirt poor. At least this guy will stick up for me.
I suppose the deeper point you're getting at, Michael, is what is the utility of these intellectual constructs if they are serving more to divide than they are serving to cast light that moves us forward, right? And I think anybody in the academy who is engaged in these constructs needs to have the wisdom to know when constructs have utility and when they do not, and when they do not to be rigid in our thinking and trying to think of what are we trying to achieve. And if what we're trying to achieve is to eliminate, is to shed light, not just create heat, then I think we need to ask ourselves, what is the right approach to advance our thinking? What's the right framing for our science? And sometimes that framing, perhaps frequently, the right approach and the framing changes and evolves over time.
Yeah, I agree. I guess my point is that I don't want to have a privilege of being white. That should be irrelevant. Okay, maybe it's not yet. We're not there yet. But I'd like to think we've made moral progress since the civil rights movement.
Oh, and just to be clear, of course we've made progress. And it's also true that while we've made progress, we also have a lot to go. I go back to the Hans Rosner part.
Yeah.
The world's a terrible place, but the world's a much better place than it's ever been.
Yeah. Okay, so from a public health perspective, let's just take these race or class differences in outcomes from COVID-19 or any other disorder. It could be heart disease or whatever. Obesity apparently is another one. What can we do about that? What do you recommend?
Well, these race differences, class differences are come from a whole range of factors, right? They come from exposures early in life. They come from the conditions in which we are born. They come from all the way from risks accumulated where we're breastfeeding or not, environmental exposures that we have as infants, the foods that we learn to like as children, whether or not we pick up smoking in adolescence, whether or not we have jobs that are stressful or not in early adulthood, whether or not we have the resource to have stable housing in middle age, whether or not we have the conditions to be able to retire at an age where we can still enjoy life. So like all of these factors, right, accumulate. So there is no single magic bullet. What I do think is perhaps one of the positives of COVID, which is hard to say, to find what are the positives of such a tragedy, is that things like health inequities have become something that we talk about, and we talk about more and more. The World Economic Forum issued a zero health gaps pledge, which I don't know if you've seen, which, these are normative organizations that issue these statements and these pledges, which they do have a value in terms of giving us signposts of what we want to aspire to as a world. But to eliminate, even the word eliminate is a very ambitious word, to narrow health gaps, right? It requires effort at multiple levels. It requires effort that starts all the way from infancy all the way through older age, and to building a world that generates health and makes it accessible as much as possible to as many people as possible. Because surely you and I can agree, right, that a dramatic health difference in your risk of heart disease should not be attributable to simple luck of birth, to where you happen to be born and what your skin color happens to be. And I think the aspiration of those of us who care tremendously about health inequities is that we remove as much as possible that difference that is attributable only to these ineffable forces that have nothing to do with choices we make with our life.
Yeah, so here you have these kind of deep root causal vectors, like class and race is really a proxy for something else. Like in the neighborhood, what do they call it? That a food desert or something, where there's just no high quality supermarkets anywhere within driving range of your house. And so you end up buying crappier food. And so you're lowering your health by, 1% or whatever, but you add the quality of the air or, whatever else is in the neighborhood that brings your health down.
The food desert is a perfect example, right? It is, and we should be very clear that the skin color, race, is negligible in terms of its association with any biological health outcome. It is everything that accrues to these racial differences that we document are due to our exposures throughout our life. Food deserts is a good example, right? And often what you find in the political shouting match, right, is people say, well, people are making poorer choices. Well, you make choices that are within the choice set that's available to you. If you have a food desert around you and you only have foods that are calorie dense, nutrient poor, well, that's what you're going to eat. So our role as a society is to make sure that we create the water. I go back to my goldfish and the goldfish water, in which we can all swim, in which we can all be healthy, and to make sure that we're all educated enough to make the right choices. And this all ends, we also respect individual autonomy at the end of the day, that individuals can make their own choices.
I wonder if the government could do something like tax breaks for, supermarket chains that build supermarket outlets in poor neighborhoods, and we're going to lower your tax rate or something as a nudge to get you to do that.
I think the answer to questions like that is, that's interesting, and we should discuss that. And I mean that. I'm not saying, I hope you don't take it as me being dismissive about it. I actually think those are the kind of creative solutions that we should be thinking about, that as long as we're animated by the right aspiration, in this case, the aspiration is to remove structural forces that are unfair and that keep some people unhealthy while make others healthy, then we should think about what are the interesting policy efforts that we should take to narrow those health gaps.
Yeah, I really like Cass Sunstein and Dick Thaler's idea of libertarian paternalism or choice architecture, where, and Sunstein was it Sunstein or Thaler? One of them worked for Obama administration on designing choices for governments to make, state governments. Say, for example, I use the organ donation. In California, I have to punch the little tab on my driver's license that says if I'm killed, I will donate my organs. In Oregon, it's an opt-out. You will be donating your organs unless you punch the tab on your driver's license that says I opt out of it. And they have a much higher rate of organ donation in Oregon than in California, just because of that simple opt-in, opt-out choice. That's the kind of thing what they call it libertarian, because you don't have to do anything. You're free to, you still have the choice, but we're going to nudge you to doing something that is collectively better for society.
And as you know, in countries like the UK, they've actually created whole government offices that are about creating better choice architectures and that try to create opportunities for better behavioral choices, and that should be part of how we structure our societies, and those should be the kind of conversations that we should be having. Absolutely.
Yeah. Well, I think since you mentioned in your book UBI, reparations for slavery, and so on. I know your book's not about that, but that's the kind of thing I say. Well, okay, what's the problem that needs solving, and what can we do to nudge people to encourage them to whatever it is, home ownership or move into healthier neighborhoods or whatever, and just giving money, I'm not sure that would work in terms of what it is, your outcome you want to achieve, versus, again, tax incentives or whatever. I mean, the government already does this. The examples I use is apparently the government wants me to own a home because it allows me to deduct the mortgage on my the interest on my mortgage, right? And it apparently wants me to be married because I get a break for that. And apparently wants me to have kids because I get a break for having kids. And drive an electric car. I have an electric car. I got a break to do that. So government does this kind of stuff all the time anyway.
Well, this goes back to the point that I made earlier in our conversation. When you said something like, Americans don't like following rules, to which my point was, Americans follow certainly if rules, and if not rules, they follow incentives all the time. And my life and in your life, we make choices within choices that are presented to us, and all societies are like that. That's it is a myth. It is a myth that somehow we have a complete choice freedom in everything we do. No society allows that, and
right.
And that's all right. But that, of course, calls for a vibrant, non-censorious, non-vituperative public square that allows the airing for pros and cons of the full range of decisions we have to make as a society. And that's what the book's about, of course.
Yeah. Here's your bias, the opening of my bias in favor of living. If presented with a choice between, on one hand, absolute safety at the cost of the interactions and experiences that make life worth living, and on the other, having these experiences with the understanding that they entail some risk, I'd choose the latter. So I guess that's the kind of the bottom line for you here. But then you write about, in your chapter, the false choice of diversity and inclusion versus the pursuit of excellence. This is the kind of story that gets, right-wing heads to explode. In April 2021, United Airlines pledged to train 5,000 new pilots by 2030, no fewer than half of them women or people of color. With this announcement came pushback, including a common objection to efforts at diversity and inclusion that extends back to the start of the debate concerning initiatives like affirmative action. That in making room for historically underrepresented groups, we risk elevating concerns about identity above a commitment to excellence, right? So you go, well, I don't want my pilot to be a diversity hire. Or my surgeon or whatever. I want my surgeon and pilots to be, pure meritocracy. All right, how do you square that circle?
Well, you want your pilot, your surgeon, your anybody who does anything to you to be excellent. There's no question about it. The fallacy in our thinking over time has been that the only people who can be excellent are people who have a certain type of identity. And of course, that is simply false. I mean, it is self-evidently wrong. And the fact that only people with certain identities occupy certain professions must make any fair-minded person pause and say, wait a second, we're doing something wrong here. So all those efforts should say, when those efforts are done right, is let us create the pathway so that everybody, regardless of their, let's remember, these identities are superficial. Race is skin deep, literally is. Genders, these are superficial identity markers. They have nothing to do with our capacity for excellence, our capacity for hard work, our capacity to contribute to society. And our society is stronger when everybody, regardless of identity, can actually achieve excellence in any field. We should not compromise on excellence, not for a second. I mean, I don't want to compromise on excellence in my surgeon. I don't think either do you. Or in my pilot, neither do you. The point is very simple. We don't need to make those compromises. We should simply create the pathways so that society can have the most excellent people rise to the top and do the hardest things that we need done.
Yeah. John Haidt, in his book, Coddling the American Mind, I think it was, used the example of the integration of the U.S. military post-World War II, where members of different racial groups did not score as high on these aptitude tests as the white groups. So they just trained them until they gave them extra training until they got their scores up. And they did, because the capacity is clearly there. It was educational or whatever background and so on that they overcame. And so, Haidt's point was, we can do this elsewhere. So don't lower the standards, but just increase the training to get everybody, raise everybody's abilities up there.
And that is what an effort to ensure equity and inclusion should do. It's not about lowering standards. It should never be about lowering standards. It should simply make sure that everybody has a fair chance. And I would use the word fair very clearly. Everybody has a fair chance to exceed and excel. And this goes back a little bit to the point you made about privilege earlier. I think, again, fair-minded people should not have a hard time agreeing that we should all have a chance with hard work and ambition to be excellent, irrespective of the accident and lottery of birth. I think that is what a diversity and equity and inclusion effort should center on.
That sounds good. I would agree with that. But then you get people like Ibram X. Kendi that say, if we don't have perfect representation in all fields, 50% female, male CEOs of Fortune 500 companies, for example, or 13% African-American coders at Google, whatever it is, then the only answer could be there's still discrimination, as opposed to just interest differences or just randomness.
Well, we can make arguments about any of these statements. The fact is, there's no such thing ever as perfect representation, because we can divide all the boxes into multiple intersectional boxes. Right. Go on until reductio ad absurdum. I think the essence of the argument is that there is no reason to believe that superficial identity differences will determine who can be excellent in particular fields or not.
Yeah, I agree. All right, here's I'm going to go to page 1 because I think this is the deeper problem. In the winter of 2022, when let's see, what is this? On the way, one of my weekend traditions is to go running every Saturday morning when I'm in my hometown of Brooklyn, Massachusetts. On the way home, as a reward for exercise, I typically stop at my favorite bakery to pick up bagels. In winter 2022, when I finished the run, I noticed a note on the bakery door. While we know the indoor mask mandate has been lifted in Brookline, we will continue to wear a mask to shop until further notice. And then you write, it struck me as remarkable that the bakery proprietors presumably knew the town had consulted public health officials when making the decision to lift the mask mandate, and that the policy was supported by science. So then you give your interpretation of what the note was really saying. The owners of this establishment are aware that public health experts have concluded the science no longer supports the need for mandatory maskings in settings like this. However, we're choosing to ignore this guidance because we fundamentally distrust public health experts. We prefer to follow our instincts and ask you to do the same. That's the problem I think we face now. It's huge. It's deep. I mean, if we have another pandemic and whoever has Tony Fauci's job says, all right, we're closing the schools and you all have to wear masks, I don't think people are going to do it. I don't think it's going to happen. There'll be riots in the streets because of this.
I don't think it will either, which is actually why we're having this conversation, because slowly we need to rebuild the trust. And I told you earlier, my New Year's resolution is leaning into hope. So my hope is that we will get there again. And the very fact that you, the skeptic, are entertaining this conversation surely is a step in the right direction, Michael.
Oh, well, I'm just, interested in solving problems like you. I just make tomorrow slightly better than today. I like Kevin Kelly's description of this protopia. Forget utopia. There's no there. But just make tomorrow just a little bit better than today.
I can get behind that.
All right, Sandro, thank you so much. Here it is again. Within reason, a liberal public health for an illiberal time. All right, let's get back to those good classic liberal values. Thank you so much, and good luck with the book. Hope it does well. It's important, really important.
Thank you. I appreciate it.